All right, folks. Well, here it is. I've really wanted to do this podcast for a while. I was waiting for the right guest, and here we are. We have the two amazing guests coming on Healthcare Filtered for the first time. And if they play their cards right, they may come again next time. But we are going to talk about advanced practice providers and how they are integrated in oncology care. And I don't have a lot of stats. I really wanted to do that and try to know the numbers and figures in terms of number of APPs and things like that. So we'll see if our guests know. And if they don't, they probably can make things up. So let's get started by some form of introduction. Both of my guests are from Emory University Winship Cancer Institute. So we'll start with you, Sarah. A little bit about you, who you are, where you work, and what got you interested in becoming a nurse practitioner.
Sure. Thanks for having us, first of all. So I'm Sarah. I'm a co-lead alongside Katie of the Malignant Heme Services at Emory main campus. And I have a nursing background. I wanted to be a nurse since I was little. I was a candy striper when I was in high school at the local hospital. And then I ended up going and getting a finance degree at UGA. I got sidetracked somewhere along the way. But after I got done with the finance degree, I quickly realized that I missed being around people instead of computers and spreadsheets, and went back and got my nursing degree. And I was a critical care nurse for about 5 years, and then loved nursing, bedside nursing, and being able to be with the patient and their family members, but wanted to take it a step further. And I went back and got my acute care degree at University of Alabama in Birmingham. And then I worked in home critical care for about 5 years as a nurse practitioner, and now I'm in oncology for the last going on 6 years at Emory. And I'm
what an amazing journey. I'm always fascinated by someone who has a degree already and completely switch, right? I mean, you don't think you go through the finance route and you're thinking you're going to be in the corporate world and doing other things, and you completely pivoted. So I could tell that this is something you're passionate about, to be able to do that, because it's never easy. So thanks for sharing that. Katie, what about you, and what got you into PA school, and how did you end up in oncology?
Yeah, I'm Katie. I'm Sarah's other half. I have this distinct memory of being in college and someone asking me, where do you see yourself in 5 years? And I was like, I see myself in a hospital in scrubs. And here I am. So I worked after college. I got my bachelor's in psychology, and after college, I worked in a infectious disease clinic as a phlebotomist medical assistant for a couple of years before going to PA school. I went to PA school at Emory. And one of my favorite didactic sessions in PA school was the HEMONC section. And so I did an elective rotation with the group I'm at now, and I've been with them ever since. And I love it. I don't see myself anywhere else. And just for the record, Sarah still uses her finance background. She makes spreadsheets all the time.
All the time. You can take finance out of the girl, you can't take the girl, or you can take the girl out of the finance, you can't take finance out of the girl. But yeah. We have to be careful. She's a psychology degree, so she can tell what we're thinking. We're going to be careful. So let's talk a little bit about. I want to try to understand for listeners. Katie, you're a physician assistant, but Sarah is a nurse practitioner. Help me and help them understand how you can have two completely separate degrees, separate schools, different degrees, but the scope of work is completely the same. You can understand, you can appreciate that people may be a little bit confused about this. And let's say if I want to do the job that you're doing, why would I decide to do nursing, then nurse practitioner versus PA, right? If I'm going to do the same job, how do I decide? Like, why do I choose one path versus another? Katie, I start with you, and then I'll want to hear from Sarah as well.
Really, I think the difference between them is really kind of the model of which they're based on. So from my understanding, that nurse practitioner school is based on a nursing model, and the PA model is similar to a med school model. So for me, I wasn't a nurse, so I wasn't already in that field. So this was the quickest way to get to do what I wanted to do. In my brain, it kind of is similar to DOs and MDs can do the same thing. And that's kind of how I think of our roles, as NPs and PAs can do the same thing.
So for you was 4 years of college,
Mhm.
and then how many years is PA school?
I did 4 years of college. PA school is around 29 months or 2.5 years.
Okay.
Most PA schools require that you have a set amount of hours of direct patient care experience, whether it's 2,000 or 4,000 hours. It varies based on the school. So that's why I worked in an infectious disease clinic in the gap there.
And then you finish PA school, you're a general physician assistant. You could do any type of clinic, or you need to specialize. What's the trend?
I think, as time goes on, the trend is getting more towards specialization. There's lots of APP fellowships that exist now that didn't exist when I was coming out of PA school. But one of the neat things about being a PA is, let's say, next year I decide, hey, I want to go work in an outpatient clinic. I could do that with my same degree, no different schooling.
Got it. Okay, let's go the nursing path. So what Katie did is 4 years of college, almost 3 years of PA school, direct hours, and then is the nursing path longer?
No. So, a nursing degree, a BSN in nursing is 4 years. And then to go back to get, there's various nurse practitioner degrees. And I think that's sort of the difference, the nuance is that, so I can't see pediatrics, for instance. I got an acute care nurse practitioner that focuses very much on inpatient medicine and adults. If there is another degree called a family nurse practitioner that sees pediatrics, OBGYN, primary care, and it's more based in the outpatient setting. So I think it's just within those two tracks, and these are really become specified over the last few years, where they've just incorporated out acute care to be only in the inpatient setting and family in the outpatient setting. But I think where you start just kind of depends on me having that nursing background. I had all the clinical hours that Katie had to go get in infectious disease. I had it at the bedside at patient care. So I think a lot of nurses at the bedside that want a higher degree then roll into nurse practitioner.
Got it. Okay. All right. Now I understand. But this is pretty typical. In other words, it's not just specific to Emory or the institution. I'm trying to, anywhere you go to, if you're a PA or a nurse practitioner, you're labeled under the advanced practice providers and you do the same job. Where are pharmacists fitting in this? They are completely separate. They're not labeled APPs, obviously, because they do something completely different. So they're obviously integrated in oncology care, but the scope is completely different. Correct for listeners?
Correct. And we also, I think specifically to oncology care, we have clinical pharmacy specialists too that work with our patient population that are even further specialized than just regular PharmDs.
Got it. Okay. Got it. So let's go through the goal of this is just to explain the scope of the work and how you're involved in patient care and try to imagine how the future looks like. So Sarah, 20 years ago, do you know how were there nurse practitioners 20 years ago, 25 years ago? Is this like, when was there a movement that started that brought nurse practitioners and physician assistants to the bedside? I'm just looking back at when I did residency. I don't think there were many. There were, but there wasn't as many as now.
Yeah, no, I think that's a great point. I'm thinking back 20 years ago, and when I was a nurse at the bedside, there was definitely not as many advanced practice providers, and even back then, I think we called everybody mid-levels, which is a no-no now. But there were fewer of them, and I think the advancement over the last probably 10 years of bringing APPs into practice and expanding access to care and doing a lot of the things that were previously set aside for the physicians only has been incredibly helpful in terms of patient care, providing quality patient care.
And there's I love that you mentioned the mid-levels thing, because one of my pet peeves, I think it is, I don't think it's an appropriate terminology, but at the same time, I'm going to challenge you with the term that physicians usually are and they don't like to label everybody as provider, but we'll go over that in a little bit. Although I actually don't care, but I know some of my colleagues do. Katie, how about the trends for PA schools? Do you have any, I don't know if they taught you this in PA schools, like, are admissions higher? Are there more people? Is it more competitive? Like, tell me about the trend and what's been going on in PA schools for the past decade or so.
Well, if I can, I'll start a little bit earlier than that. The PA profession was actually born out of the military. So they would have these army medics, and that is where the PA profession came from. I think they noticed that PAs can provide that acute quality care to patients and fill a gap in healthcare. And that's where the profession came from. And then I think over the past decade, as people have become more familiar with the profession and healthcare needs have increased, admissions to PA school have also increased. I graduated from PA school in 2015. And when I applied, I think there were something like 1,000 applicants. And I'm now on the interview panel for the PA school, and they get, thousands and thousands of applicants a year.
Wow. How many, I could Google this, but why Google when I have you? But do we know how many like PA schools are out there in the, like every state has a PA school? You don't need to travel out of state if you have to stay in state, no?
Every state has a PA school and some have multiple. In Georgia, there are several.
Okay. Okay. Got it. Okay. So Sarah, what do you do day in and day out as a nurse practitioner on the inpatient side? And obviously you have colleagues on the outpatient. I'd like you to tell me what they do. We don't have somebody on the outpatient side that is with us today. Take me through a day in the life of Sarah.
Sure. So we typically have around 8 to 10, sometimes more, patients that are assigned to us as an APP. And so our day-to-day as we go in, we look up the patients, see what happened overnight, touch base with the nurses. We go and see every patient on our list, make any initial adjustments to their medications, like if they're having more nausea and we need to increase the nausea meds, or if something acute happened overnight and we need to make any changes. So we do that. And then we do what's called multidisciplinary rounds. Is an initiative that we have recently started and are still working on getting down, but from 9 to about 12. And that's so the APP, the physician, the clinical pharm specialist, nursing, and where we go and see every patient on a set list. And then after that's done, the afternoon's generally filled with, we'll do notes, call consults, do procedures, and then inevitably there's upwards of 8 to 10 sick admissions or scheduled admissions for chemo or patients transferring from other facilities that are newly diagnosed and need workups.
Is there a limit to how many patients are under your care for in the inpatient setting?
No, we do what we have to do to get the patients taken care of. I will say that the goal is to have 8 to 10, just because we are taking care of the whole patient. It's not just, it's basically, we're a primary service. We do all the internal medicine, and a lot of times, so 10 patients again is our goal. And we are very fortunate that we do have fellows that rotate on the service, and even sometimes the attendings, if the lists are getting too big, will offer to take a handful of patients themselves.
Got it. So Katie, at night, what happens? You obviously leave at some point, depending on your workload. Do you have are there different PAs or NPs that come at night that stay overnight and sleep in the hospital?
Yes, well, I hope they're not sleeping, but we do have a dedicated team of night shift APPs that cover all 4 of our inpatient oncology services. So they cover BMT, our lymphoma myeloma service, the leukemia service, and the medical oncology service. They're there from 7 p.m. to 7 a.m.
So what do? They're taking care of acute things, but aren't there residents and fellows also at night at the hospital? What?
So our service is entirely APP managed. During the day, for the most part, we occasionally have fellows come through. I would say maybe 5 months, sometimes a little bit more on the leukemia service, but night shift is entirely APP run.
But the medical oncology, there are no residents or fellows on call?
Nope.
They take call. So the outpatient phone calls go to the physicians So they take outpatient phone calls, but in terms of being on call and in the hospital, it's all APPs.
Yeah, so they are handling, putting out all the fires, doing any admissions that come in overnight, and then just kind of, the routine things that come up overnight. Someone spiked a fever, we have to do a sepsis workup, everything like
So
that.
let me get this straight, because that wasn't the case when I was in training. So the fellows and the residents, they don't take overnight oncology calls in the hospital. How about during the day? Are there, I'm not talking the BMT. I realize the BMT may be different, but I'm talking the other ones like lymphoma, myeloma, you said, and medical oncology, these are less acute of services. No, they don't.
No.
Okay. All right. That's interesting. So how about the weekends? Do you take call on the weekends, Katie?
Our service is staffed 24 hours a day, 7 days a week by APPs. So Sarah and I worked both Saturday and Sunday this weekend. So
Okay. And then next weekend, hopefully somebody else will take over, so you take a weekend off.
yeah, we don't work
Wow.
every weekend, but yeah. And we
Yeah.
sometimes fellows are allowed to moonlight on the weekend. So sometimes they'll pick up an extra shift, and if we need help, they'll come in and staff it with us.
Got it. How about outpatient calls, Sarah? Are you involved in outpatient calls? Like in other words, no.
So are you talking about like the phone calls that come in after hours or?
Right, right.
Yeah, no, we're very lucky that the physicians field all of those.
Okay. And the fellows and residents take calls or no?
Mm-mm. No.
I'm going to go back and do my residency there. What is this? The hell is that? I think listeners will know I'm usually very rarely at loss of words. Let me tell you, I'm a little bit at loss of words. I mean, like, they should have some training, shouldn't they? Okay, got it. So now you obviously do the same that Sarah outlined. So now, Katie, take me through the discharge process of a patient, and how is the sign out to the outpatient team? Take me through that process that's going on.
Our discharge planning starts on day of admission. So we start the process up front because they're very complicated patients that require a lot of specialty meds and close follow-up. We're lucky enough to have fabulous discharge coordinators on our team. We have 3 of them, and they help us with arranging follow-up, outpatient imaging, getting labs scheduled, sending messages to the clinic to make sure that the outpatient team is on, the same page as us. We've standardized our discharge summaries so that we include a specific section that says outpatient team to follow up on, to try and make it, very clear. They had a long hospitalization, but hey, here are the 3 things that we really don't want to fall through the cracks. And then sometimes we send our patients home to a local physician. And so we created a tip sheet essentially that is like, on day 30, you need to start Bactrim. Here are the labs we recommend. Problem solving for nausea, vomiting, uncontrolled diarrhea, and things like that. And we make sure they get our discharge summary as well. It's all about, transparency and communication.
Yeah, I mean, it's really no easy task, to be honest. I mean, your patients are pretty sick, and you've got a list of these things. But Sarah, if I may, I presume that some of the patients that get discharged, they have never been seen in the outpatient clinic, because you could get a patient coming through the emergency room, they have acute leukemia, and they end up being all in so they haven't been seen. And when this patient is discharged, they may still call the floor, and they call the nurse and they ask for you. They've been with you for like 4 weeks. And how do you handle that? I mean, because now they're out, and they're in that limbo phase.
Sure. I would say that Emory does a really great job of sort of that transition of care. Any newly diagnosed patient, whether it be myeloma or lymphoma or leukemia, for instance, every patient gets a phone number that directs them towards when they leave. And it's a 24/7 where they get one of the physicians that are on call from our services, and they can direct them towards. We just opened an intermediate care unit. So we have the infusion center that can take care of patients. And then we have a Rollins intermediate care unit that just very recently opened, and it's for our oncology patients to go for things like if they need blood cultures done, or maybe to be worked up for a neutropenic fever, but don't necessarily require hospitalization. So, and that's all sort of directed by that one phone number that the physicians take call for.
And that's available 24/7, the intermediate unit?
It's going to be. It's right now it's open 6 days a week, I think 7 to 10 p.m. And then once they get staffing for the full 24 hours, it will be 24/7.
Yeah. Okay. Let's talk about some of just a little bit of a few other things that are really important for folks who are listening to understand the scope of what we do. So let's talk about autonomy in decision making and test ordering. Katie, give me an example of things that you don't need to call the doctor for and things that you need to call the doctor for.
I would say, anything that falls under the day-to-day management of patients and a lot of symptom management we do. So medication changes like titrating antiemetics, or patient has a neutropenic fever, adding on antibiotics. They have an acute abdomen, you order a CT scan. The day-to-day management of a very sick patient, we do. And then things like we do bone marrow biopsies and lumbar punctures. We take care of the ordering for that as well. If we're unsure of something, the physicians are amazing and we can run it past them and they help out with the specific, if there's FISH or molecular testing that they want to make sure they get done, we can run it past them. Things that we do have to call the physician for, I would never change chemo without running it past my attending. And then we do a lot of CAR T-cell therapy. So if we need to give tocilizumab or dexamethasone to a patient, I would be sure and loop the attending in as well. But
how about dose reductions?
Any modification to a chemo, I would loop the attending in.
Growth factor support.
Growth factor support is in our chemo order sets, so it's kind of autopiloted.
Got it. So with, I mean, that's very important in terms of all of that. So now, how do you keep up with everything happening, Sarah, with the field of oncology and heme malignancies? I mean, you take care of a lot of these patients with myeloma and leukemia and CAR T and everything. I mean, this is such a fast-paced field. And so do you go to conferences, in-state, in the hospital, outside? Take me through how you keep up with everything.
It's hard. I mean, it is, but this is truly one of the things I love about doing oncology care and taking care of this patient population. There's so much in terms of research, and we're learning daily about new treatment options and things like that. But in terms of how we sort of try to keep up as a team, we one of our APPs started a monthly journal club that looks at recent articles that came out from ASCO, or basically any article, scientific journal article, we'll talk about as a group every month. So we're doing journal clubs. We go to M&M conferences that are led by the attendings and as part of the fellowship training. We do go to conferences, both APP specific conferences. Katie and I are going to JADPRO here at the end of October, and then also some of the larger like ASCO and ASH.
Tell me about that. The October one. What's the name of the conference?
It's called JADPRO, and it's focused primarily on APPs and oncology care. So it's very specific to what we do. But it's in Colorado for I think the last week of October.
Okay. So, and that's like the annual APP kind of conference, like similar to the ASH that we.
Yes.
Okay. And you could go to ASH or ASCO if you want to, but I have a feeling that you probably stay put because the physicians are going to that. I'm just trying to think.
I will say that we're working towards sort of at least sending one of our APPs because there's a whole group of us, so we could certainly spare one. But yes, you're correct. I think a large portion of our physicians go to those larger conferences, and so we are usually there taking care of the patients. But that's one of the sort of initiatives that Katie and I are working on, is getting sponsorship to go to some of the larger conferences to have access to all the information and research that's going on.
I have to say, if you have to choose and lobby for something, maybe don't lobby for the big ones, lobby for the ones that have like the updates, because I mean, the big conference is like a zoo. I mean, I'm just telling you, like everybody's there.
Overwhelming.
It's very overwhelming. But sometimes they do like a day and a half of really concise ASH updates or something like that. These are the ones that are really, I believe, you get more ROI. Okay, great. One of the most contentious things that happens with advanced practice provider, I'm not going to say most contentious, but it does happen. And you both are a little bit new to Twitter, so you will see a lot of back and forth and fights on Twitter. But physicians sometimes get a little bit upset when they are called providers. And they say, well, we are doctors, we're not providers. But in disclaimer, I actually don't care. I even taped a video about this, I don't care, and I was attacked by my colleagues. but there's a sense that, sometimes the advanced practice providers are doing more than they are supposed to. And if we really label the doctors and the APPs under the same umbrella as providers, then the higher ups in administration, they will easily replace provider by another. And they will say, well, you are all providers, so we don't need this doctor, we'll get the APPs instead. And we all know doctors get paid more than APPs. So from an administrative perspective, they are saving cost and money. I want to give you the rationale behind the fight, I guess, over the labeling. So as advanced practice providers, my two questions: A, can you understand why some physicians are upset by that label? B, do you really think it's an issue, and what are your thoughts about it? So we'll start by Sarah and we'll go to Katie on that.
I guess, to each their own. However, I think it's semantics, honestly, the difference in being called provider versus, physician versus APP. That being said, physicians go to school for a lot longer than us and have so many, I think the skill set is different, for sure. But I think there's a place for both APPs and physicians, and we can work collaboratively for patient care, honestly. I would say that we are sheltered at Emory. There's not that mentality, or at least I have not come across it. It's very, I think our physician group and our physician leads are very APP friendly. It's very collaborative.
Well, yeah, I mean, Sagar Lonial wants me to call him sir. Are you kidding me? I mean, So, Katie, I mean, do you understand the reason behind this? Like, little bit of a uneasiness, because they say if you call us all providers, then the CEO of Hospital X, they say, you know what, I'm just going to replace these 2 doctors by 2 PAs, and I'm going to save a lot of money, and they're all providers.
Yeah, I mean, I think intellectually I understand what you're saying, but again, we're so sheltered. I just don't actually see it happening at Emory. I feel like doctors serve one purpose, and the APPs kind of fill in the gaps and serve an entirely different purpose. There are things that doctors do that I wouldn't do. I know it's outside the scope of my practice, but I also think that there's a lot of doctors on our team who are like, I can't do what you're doing. So, and I think that goes for every member on the medical team, nurses, discharge coordinators, pharmacists. So I don't know, I just haven't run into it.
So one of the things that Sarah mentioned earlier is that, or maybe Katie, you mentioned that you do all of the procedures, which are at least in the world of oncology, it's bone marrow biopsies, intrathecal chemotherapy, lumbar punctures, and I guess maybe sometimes you could do, thoracentesis, and, I mean, I did a few of those back in the day. If you are doing all of these, how are the residents and fellows being trained on doing these procedures where they have to do that when they leave the hospital? Katie?
Great question. We're usually the ones that are teaching our residents and fellows. And even when they're on our services, we're really the ones that are doing them. They're not. I don't know if it's different maybe at Grady or other places where the physicians are teaching the fellows how to do it and the fellows are running the services. But it really falls under the APP scope of practice. That being said, we do have a procedure skills lab, or we did pre-COVID, where we would have cadavers, and the fellows would come to that as well.
So, Sarah, you can understand why this is an issue, right? I mean, I think fellows have to learn this to graduate, but Like, I can see if they're learning from you, but are they eventually doing something? Like, do they do any of these procedures?
Yeah, and I think like Katie said, and this might just be us not working at Grady and knowing Grady. I mean, I think Grady and at the VA, I believe, maybe I might be speaking out of turn, but they do the bulk of the work and the procedures, and it's very much fellow driven. Just at Emory main campus specifically, with all these specialized services, it's always truly just been APP run.
Okay, got it. So let's talk about a couple of things. Also, I'm sure my listeners are thinking about in terms and some of this scope of practice and what you do. Are you, Sarah? Do you initiate end of life discussions? Do you participate in them, or you run them? Are you the one sitting and having this conversation with the family? Unfortunately, this is the worst part of the job. So how are you involved in that unfortunate part of the job?
Sure. Yeah, I mean, it's definitely part of our job. It is unfortunately, I would say, a good portion of our job, depending on sort of what service we're working on. But the APPs very much do and can initiate those types of conversations, usually at the behest of either a family member or, as Katie had mentioned, like we're there for 12 hours. And so we're really at the bedside, along with the nurse. A lot, just for a lot more time out of the day than the physicians are. But we do have, a fantastic palliative care team too. So they usually are involved at some point or other. And then if it's treatment related decisions or a conversation where the patient's just not a candidate for additional therapy based on comorbidities and whatnot, then the physician usually does step in too and weigh in and say, this is what I think.
Katie, are you involved in having the conversation about code status?
Oh, yes. Yeah. I mean, on every admission, we address code status, just as part of, doing a thorough H&P. I was on our lymphoma myeloma service actually over the weekend and unfortunately had a very sick list of patients, and two of them ended up going to hospice. And, we were going live with Epic at the time. So it was really me who was there doing the code discussion and making those changes and initiating the transfer to hospice. We're lucky enough to have a collaborative MD team that there's a lot of collegiality wherein kind of sharing the workload where, I may speak to a family member and they may speak to a different family member, kind of sharing the process, sharing the load, and taking care of the whole patient and their family.
Are you involved in teaching other staff in the hospital? You mentioned teaching the fellows and residents some of the procedures. What other teaching do you do, including to the nursing staff, Katie?
I think we teach every day. If a nurse comes in and is like, "Hey, I don't understand this decision," teaching in the moment. And then we also there's all these APP education sessions. Every year they put on a procedure skills lab where I go and teach anybody who wants to come how to do a lumbar puncture, for example. But I think there's education and teaching that's done, every moment of every day.
But do you have anything structured, Sarah, like, weekly lectures, anything for the staff, or just ad hoc?
It's mostly ad hoc. I mean, I think eventually we'd love to see something structured. It's really hard on an inpatient setting on a busy service to have, say, every, Wednesday at 3:00, we're going to have, an hour long discussion. Because obviously when we're there, patient care comes first, but that's not to say that we don't need, the other things, the other portions of that, which are education and teaching. And the physicians are really good about doing it on rounds a lot of times too, if a certain situation came up, and then nurses are present for that as well as the pharmacists. So you get a good group right there. And it's very applicable to what's going on with a certain patient.
Mary, I think I have a good idea in terms of what you do, how you spend your day, where you get the information from, and all of this. So, Katie, what's the worst part of your job?
My friends who aren't in medicine kind of look at me and they're like, "Hey, you get to cure cancer every day." And I think that's a very optimistic way to look at it. And I think, unfortunately, a lot of the time when patients are in the hospital on our service, they're at their sickest, their disease is progressing. And we see a lot of death and dying, and that's difficult, emotionally. That's hard to see. I think that's the most difficult part of our job.
Sarah, if we take that aside, because I agree, it's probably the most difficult thing from the, I don't know, logistical, administrative, anything else, what's the part of the job that you really would like to improve on?
I would say, and I think this has been not unique to oncology, but I think burnout in the last few years with COVID and, just healthcare in general, and being able to step away from it when we're not at work has been hard for me personally.
Are you able to shut down?
Not as well as I would like to. I think a lot of it came along with a leadership role. So if Katie's we try to separate our schedules. So either Katie's at work or I'm at work, so we can have time away. But 9 times out of 10, somebody's texting about can't find the overtime sheet, or, how do we do this in the computer, which we don't mind and we love, and we have a very open, we want our team to be able to do that and ask us those things, but it is also hard to take time away.
Yeah. So you mentioned, Katie, both of you actually mentioned about COVID. Obviously we are emerging out of the pandemic, and of course I may get canceled right now because I said we're emerging out of the pandemic, but we are. But what? How did your role change during the pandemic from before the pandemic, Katie?
Significantly. We actually had to create kind of a Jeopardy system. So we transitioned our entire inpatient service from working 3/12s a week to working 4/12s you had a buddy essentially. So one person was in the hospital and the other person was at home charting and calling consults. And it essentially changed that person into the safe zone. So if the person in the hospital got sick with COVID, their buddy would come in and take over for them. And that was a significant change, I think, for everybody. That, of course, ended. That was a short-term solution. But COVID, I think, changed our jobs entirely. Lots of things are done on Zoom, telemedicine. People kind of expect that immediate access.
Yeah. What are your thoughts, Sarah, about these changes that occurred? In all transparency, I would say I've tried to stay away from having a lot of COVID discussions, but the one thing I really was very vocal about, well, 2 things, but the one thing that is maybe relevant, I always felt uncomfortable and it's inhumane to not allow family members to see their patient, their loved one. I understood that the rationale, but I disagreed with it because I felt, we had PPEs, I'm sorry. We had, people were able to wear masks and all of these things. And to say goodbye to a family member on FaceTime, it just really honestly broke my heart. And I completely disagreed by not allowing family members. You were on the front lines, you were right there, and you probably have seen that more than once. Tell me what you went through and how you felt about it, and whether you really agreed with the policy or not. Don't worry, nobody's going to do anything about your opinion.
It was really hard, especially early on. And I think when we didn't have all the information that we now have. I mean, I think hindsight's 2020, but we, especially working on a transplant floor where our patients have zero immune system, that are highly susceptible to, and we don't allow children on the floor during cold and flu season. And at baseline, this is pre-COVID. And so now you've got this respiratory, virus that, honestly, we had a couple transplant patients that ended up getting COVID in the midst of their transplant, from family members. And, you can imagine the outcome. So that was very hard to watch. We luckily, didn't have to, I did not personally have anybody that I had to have say goodbye via Zoom.
Yeah, I mean, I guess I was okay when you can limit the visitors if the patient is fine. I'm not disagreeing with that. I think where I had a very where I felt uncomfortable is in the end of life situations. I mean, of course, like you said, if a patient undergoing transplant, immune system, and so on, we limit the visitors anyway, even without the pandemic.
Correct.
But I think when you are actively dying and you know that you have, I mean, that's where I struggled with this. I know. Katie, what are your thoughts about this? And I know this is probably an emotional topic, but I do think it's relevant.
Yeah, you know, I agree with Sarah in the beginning when we didn't have any information and it was frightening, right? Everybody was scared and just trying to do what was best. And it's hard to do when you're in the middle of a situation. So looking back on it now, I can see how maybe that wasn't the right decision. But at the time, we really thought we were taking care of the greater good because we did have that policy, you know, no visitors. And even if you're not dying, you know, the transplant process or induction for leukemia is not easy. You're in the hospital for 3 weeks or more. You can get very, very sick. And it's mentally taxing at baseline, but add on a pandemic and not being able to have your support system at bedside. I can't imagine doing that. And I think that changed to go back to your earlier question about changing our role. We were there at the bedside for 12 hours and there were a lot of times where we turned into the family member, you know, sitting at the bedside, holding hands and being there and doing therapeutic listening for our patients. So not that we wouldn't do that before, but it turned into we were all they had, us and the nurses.
Sarah, during the pandemic and during all of these emotional times, I mean, who were you able to turn to for support? I mean, I obviously, hopefully your family, but outside of that, I mean, you probably were spending more time at work than home. So, I mean, was there a support system for you?
Yeah, and I think we are uniquely lucky. We have our physician team checks on us daily. Even this was pre-pandemic, but even more so during the pandemic. I think they very much appreciated everything that we were doing in our roles and taking care of the patients, and frequently checked in on us. We have an APP leadership team that also was very supportive and is supportive. So I think we have a lot of safeguards and just networks of people built into our roles that, yeah, it seems like they care a lot about us. It feels that way anyways.
Yeah. There's always room for improvement. Remember, don't ever tell them that. I mean, there's always room to care more and to improve. So, Katie, let's put on your futuristic hat. Like when you think of the field of APPs and what you are doing and in oncology, where do you see that heading? If we're having this conversation in 5 years from now and talking about APPs in oncology, do you see more of the same, or do you see things evolving differently?
I definitely see things evolving differently. I would love to see APPs get more involved in research, being their own PIs on studies. And then, you know, at our hospital, current practice is that APPs don't sign chemo on the inpatient service, but I think there's room to, you know, educate and have the APPs more involved in the chemotherapy process as well. Like
so
you said,
what do you mean by the chemotherapy process? Like what's
right now the ship is kind of set for us. The outpatient doc sets the plan, the chemotherapy is written, and we enact. But you know, to be more involved in that decision and make dose adjustments or involved in that process. Sorry if you can hear my dog in the background.
No, it's fine. That's why it's unfiltered. Everything is gonna get in. Sarah, where do you see the field evolving or moving towards the field of APPs in oncology?
Yeah, I think even hopefully it continues to grow and in a collaborative forward movement with our physician colleagues. You know, I think the APPs, we as APPs are slowly, you know, trying to get a seat at the table, if you will, in the sense of being involved in various committees and education initiatives and things like that. Katie and I have recently been asked to participate in physician interviews for bringing new faculty on, which has been great. And for us to be able to get how they might work with APPs and give our perspective on things. And we were invited to be on a blood conservation committee that's hospital wide. So I think things are moving in that direction. And we've got a great team that wants to be involved and cares a lot.
So tell me your toughest question to an interview candidate who is coming for a new job. Let's hear it. I'm gonna try. Let's say it's me, and you wanna throw me your toughest one.
Ooh. I don't know if it's hard, but one of the ones that we ask pretty much everybody, and it's a very common, I think, interview question, but I think it's very telling about a person's personality, is tell us about a time that you've made a mistake, a medical error, a mistake.
Well, we're doctors, we're gods. My answer would be, I mean, what do you mean? How dare you say that? I mean, I never make mistakes. Do I? That's
You're
the
not
right,
hired.
Katie, that's the right answer.
It's a big old X, 0 out of 5.
No, it's actually a good question. It's a very good question, and I can see the importance of it, and I think it's important to be humble and acknowledge that we're human. So I think it's actually also a creative question. I have not seen actually or heard a lot of folks asking that question.
I think it comes uniquely from an APP asking a physician, tell us about a time you made a mistake too,
Yeah.
Being able to answer that, I think shows a lot of character.
Do you see some folks struggle in that answer?
Yeah.
Yeah.
Yes, we do.
Yeah. I mean, some of it is culture though, because you always get afraid of saying, right? I mean, some of it is never the fact that people don't realize they make errors. It's really the implications of what that error looks like.
Mhm.
What else should listeners know about advanced practice providers? I'd love to see more involvement in social media, for example, for advanced practice providers on Med Twitter. I see few of that, and I follow them on Twitter. And I just I'm starting to follow you both as well. But what else should listeners know about what you do, who you are, the field, the involvement in oncology care, the evolution of the field, and all of that stuff?
I think, there are so many of us, and speaking from our team of however many there are, 20, ask and it shall be done. We've got a lot of young, eager folks who are smart and willing and want to get involved and want to do the work. And there's a lot of work to be done, and put us to it. We're ready to go.
And it's getting more complicated. Frankly, oncology care is getting more complicated. My goodness, I mean, CAR T cellular therapy, I presume you both were very involved in designing the logistics and the process and the treatment plan, weren't you?
Yes, we care for all of the cellular therapy patients, so the BiTEs, CAR Ts on the inpatient service. And so coming up with sort of the SOPs and management of the cytokine release and ICANS and things like that.
So you had to do that and then send it to them for approval or something.
There's a whole process for guidelines, but yes, for instance, I just worked on one about doing a bloodless transplant, and sort of for non-religious reasons. We just updated that.
Look, this has been really amazing. I learned a lot from you, and I appreciate you tuning in for Healthcare Unfiltered and being guests on Healthcare Unfiltered. I hope listeners understood how valuable your contributions are to the field of oncology and healthcare, and more importantly, your really passion and dedication to patient care. I don't think we could do anything that we are doing currently without everybody involved. While obviously physicians dictate and recommend treatment plan and the direction of care, but let's just face it, we spend the least time with patients in the inpatient setting. In the inpatient setting is everybody else involved, and really that's really what matters. So any last words before I let you go?
No, just thank you for shining the spotlight on APPs at the culmination of APP week. It's pretty special. Thank you.
Oh, it is APP.
Yes.
Well, for transparency, we are taping this on APP week, but it's not going to air on APP week. That's the issue.
Okay.
Because we have a pipeline of episodes, but I'm going to try to get this ASAP, and I'll let you know for sure, and we'll amplify it on social media. Sarah Wyman and Katie Simon, thank you so much for visiting with Healthcare Unfiltered.
Thank you.
Thank you.